Hi everyone. So this is the last video on the topic of enamel, and we'll be talking about the 8 changes of enamel and some clinical consideration that comes along with enamel and the formation of enamel. Okay. So starting with the 8 changes of the enamel, what happens as we age? What changes can we see in the enamel? So the first thing that happens is the wearing off of the occlusal and proximal surfaces due to mastication. What that means is that when the enamel is young, so you can see the smooth and maybe the cusps are pointed, that kind of surface. But as we age due to mastication, the surface will be uh, worn off. Then the second thing is the disappearance of rods. So what that means is that we have seen that not disappearance of rods but disappearance of rod ends. So we saw in the structures that there were like rods end on the surface of enamel. So due to the wearing off, they will be also removed. Okay, as the enamel surface gets worn off. Flattening of perikymata. So perikymata were these layers. They were the striae of retices on the surface of enamel that were visible. So they will be also worn off. Facial and lingual structures lose their structures more rapidly than the proximal surfaces. So the proximal surfaces are not affected a lot by mastication. So that's why they won't lose the structures a lot. Anterior teeth lose structures faster than the posterior teeth. It's because the anterior teeth come in the mouth first. Okay, so they will start losing the structures first as well. Localized increase of nitrogen and fluorine in the superficial layers. So as we age, the content of nitrogen and fluorine will increase in the superficial layers. Organic portion near the surface becomes darker and its resistance to decay increases. So you may have heard that enamel becomes harder as we age. So it does not become harder, but its resistance to decay increases because every organic portion it becomes kind of more resistant to bacteria and everything surrounding it. Okay, permeability decreases due to increase in crystal size from the ions acquired from oral fluids. So what's happening is we had this hydroxyapatite crystal. Okay, so we have like just a second, we had like two of these crystals. So there are pores in between these crystals. Okay, so this allows permeability. But as we age, what's happening is these crystals are increasing in size. Okay, they are gaining more inorganic content. It's accumulating over them from the saliva. So as they increase in size, now there is no pore. This pore, I think, disappeared. So this pore has gone away. That was providing the permeability. So this, because of this, the permeability will decrease. Okay, and it thickens due to the ions acquired from the saliva and the oral fluids. Now coming to the clinical considerations. So what do we have to take care of in case of enamel? So during cavity preparation, no unsupported enamel rod should be left. It may break, produce leakage, inducing secondary caries. So what will happen is, so I have this tooth, okay, and I'm forming a cavity. So if this is the direction of the enamel rods in this portion, so if I'm forming a cavity, if I'm making a cavity, I have to make sure that I make the cavity along this, okay, like this. If I try to make a cavity like this, what will happen is that these rods, if I made a cavity, um, just a second, then these rods will be left unsupported. Okay, let's say I made a cavity over here. Now these rods over here, they are left unsupported and they might fracture or produce leakage. Okay, so we have to take care of the direction of the rods and make a cavity accordingly. This might also induce secondary caries because if this breaks down over here, there will be a gap and there will be passage for entry of bacteria. Okay, deep enamel fissures and dental lamellae predispose to caries. So it's a similar kind of concept here, leaving like a gap. There's a huge organic content in here. In dental fissure, there is empty space, and in dental lamellae, there is space filled with organic content, which allows bacteria to enter the tooth. and it causes caries. Dental caries in children can be reduced up to 40% through the application of sodium or stannous fluoride. So we all know that fluoride reduces the caries. So sodium or stannous fluoride, it can reduce caries up to 40%. Okay. Now, moving on to clinical consideration in amelogenesis. So, what are the defects caused during amelogenesis, and what conditions can arise? So, there are two processes in amelogenesis. First is the enamel formation, and second is the maturation. That is the mineralization. So, if there is a defect in enamel formation, then hypoplasia will occur. And if there is a defect in maturation, then hypocalcification will occur. So first we'll see what is hypocalcification. As the name suggests, hypocalcification means low mineral content. Okay, it is there is less mineralization. Why does it occur? So it appears. So first we'll see what it looks like. So it appears like a opaque chalky area on the surface. Okay, and the example of hypocalcification is mottled enamel. You can see that mottled enamel over here. A deficiency of mineral content in the enamel is seen. So there is low enamel content. The enamel is soft and acid soluble. The surface appears dull and opaque. It gets discolored and gets starts getting peeled off in there. So the enamel is weak. It is soft because there is low calcium content. It appears dull and opaque, and there's discoloration. And when you masticate, it will get peeled off. Mottled enamel is an example because due to high fluoride content, the high fluoride content it prevents calcification of the enamel. Okay, so this was during mineralization, and what will happen when the amelogenesis is affected during matrix formation? That is hypoplasia. So what happens in hypoplasia? Uh, Pitting, furrowing, or a complete absence of enamel. So all these three structures, all these three conditions are example of hypoplasia. Okay, it can occur during three conditions. It can be systemic, it can be local, or it can be genetic. So what is systemic? It is due to nutritional deficiency. When the enamel in your water, when the fluorine in your water is less than 1 parts per million, it can occur. Okay, so it is due to environmental factor, systemic one. It is called chronological hypoplasia in case of systemic. It appears as a narrow band of defective enamel because what's happening is your enamel is forming, right? So maybe for this period of 1 year, you were having water that had low fluoride content. So this portion of the enamel, it was hypoplasic. Okay, so it appears as a narrow band of defective enamel due to metabolic disturbances because they generally persist for a short duration, and the disturbance will go away. Okay, so you can see this band kind of. So maybe the person had initially they had low fluoride content, so it's a mild condition. Local. So what in local hypoplasia can occur due to infection to the pulp. So uh, if this is the pulp and this is the tooth, so maybe there was an infection over here. So this area will be hypoplasic. Okay. Now, genetic. So, in genetic condition, it is disturbance of the so the entire ameloblast, okay, that is affected. So, all the teeth and the entire enamel is affected. Teeth appear yellow, brown, glossy, and hard. Okay, so they will be yellow, and even in this, they have bands, but the entire teeth will be like yellow and hard. Anomaly is transmitted as in dominant character. So remember that it is a Mendelian dominant character, which is quite interesting to read in the book. So there are not many questions asked on these topics, at least on the clinical considerations, but you can always add that on for the extra marks in the university exams. And so we have completed the second chapter. If you like videos, please like and subscribe.